let us continue with our discussion on obstetrics. So, indication of induction of labor. So, what are the different induction methods? I will just show you some image-based things. So, this is a Foley. This is a double balloon Foley catheter. This is a double balloon induction catheter. This is a mechanical induction device. So induction methods are basically either mechanical or pharmacological or surgical. Surgical is like your stripping of membranes or artificial rupture of membrane, even though artificial rupture of membrane is not commonly used for this. Pharmacological is by prostaglandins. We'll have a detailed discussion. And mechanical is what I'm showing this image. So this is a dilapan. So dilapan is basically a hygroscopic synthetic material. We can also use the organic variant of it, like laminaria tent. So basically it is inserted into the cervix as a very thin thing, and over the time it absorbs fluid and becomes thick, and by the time dilates the cervix. So this particular thing is known as ProPress. This is not mechanical, this is pharmacological. So let us see the prostaglandin. So we have prostaglandin E1, which is also known as misoprostol, prostaglandin E2, which is known as dinoproston, and prostaglandin F2 alpha, which is known as the carboprost, Okay. So E1 has effect on both uterus and cervix. So it increases uterine contraction and dilates the cervix. So it can be used as a standalone induction agent. On the other hand, dinoproston has very less action on the uterus but good action on cervix. So it can be used as an induction agent or cervical ripening agent. On the other hand, PGF2 alpha has no effect on the cervix but has effect on the uterus. So if you use this one for induction of labor, the cervix will remain closed and the uterus will contract and it will rupture. So this is not used in induction of labor, but used in treatment of PPH, right? So this is ProPress. ProPress is basically dinoproston is either given by jelly, 0.5 mg jelly, or 10 mg pessary. The advantage of putting this pessary is this pessary can be removed anytime we want, and this is a slow sustained control. Okay, next thing is, when we were discussing cesarean, we are discussing TOLAC and VBAC. So TOLAC and VBAC are not the same thing. Let us see the Quintero's classification of scar, cesarean scar. So grade 1 scar is an intact scar, that is intraoperative finding. When we open the abdomen after a cesarean, we get to see the condition of the scar. So this is thin scar, grade 2. Grade 3 is partial rupture, and grade 4 is rupture, uterine rupture. Okay, scar rupture. So TOLAC is trial of scar after cesarean, whereas VBAC is vaginal birth after cesarean. So we have discussed the contraindications for related to previous surgery when we were discussing the absolute indications for absolute indication for cesarean after one cesarean. So there you can find all the contraindication related to previous surgery or any other obstetric contraindication. Like in this pregnancy, the baby is big and she cannot deliver vaginally, like that. Those are the contraindications. So what are the malpresentations? Face presentation, brow, there is no mechanism of labor. OP, as I already told, is difficult to deliver, but normal delivery is possible. Breech, transverse, again goes for cesarean or external cephalic version. And shoulder presentation is also goes for cesarean. Breech can go for breech vaginal delivery, or ECV and encephalic delivery, or cesarean, right? So breech presentation, all the causes of breech presentation should be knowing. Most common cause is preterm, then uterine anomalies, multifetal gestation, placenta previa, cornufundal attachments, hydrocephalus. All these are common causes of breech presentation, right? So, what is ECV? ECV is external cephalic version, is a way to convert a breech presentation and turn the baby externally to convert it to a cephalic presentation. So, these all are the contraindications for external cephalic version. It can be asked as your question. Timing, it is usually done beyond 37 to 38 weeks. It is done at 37 to 38 weeks. Complication can be abruptio, sudden fetal bradycardia, and uterine rupture in rare cases. RH sensitization if the mother is RH negative and fetus is RH positive, right? So, talking about twin incidence is not really very commonly asked. These are the risk factors. Note that increased parity causes increased risk of twin and use of all the ART techniques. So ART related twin is because there is more ovulation, there is more external twins are implanted, but also monozygotic twins, because the embryo, even if we do a single embryo transfer in IVF, in vitro fertilization, the embryos are kind of unstable. So if I transfer a 4-cell stage, most of the time it is seen that they divide into two cell stage and get implanted separately, giving rise to identical twins, right? So this chart is again very important. At what weeks what happens? So this is also available in the YouTube channel, Instagram handle, Dr. Sunabha. So you read this chart. This chart is really very simple but very useful in your exam. This is a very important chart and all of you should go and see this. Okay, so mechanism of twinning is by multiple ovulation or superfecundation. Now, what is superfecundation? So, superfecundation is in the same cycle, 2 different days, 2 different ovulation happened, and they both get fertilized. Superfetation is that happened in one cycle, one fetus got fertilized, and next cycle somehow ovulation happened, and hence there is another pregnancy that happened next month. So there is a time gap in superfetation, whereas no time gap in superfetation or superfecundation. Note that superfetation and superfecundation can be from the same paternity or different paternity as well, right? So there are certain complications which are common in monochorionic twins. One of that is twin transfusion syndrome, and Quintero staging is the staging for that. Twin anemia polycythemia sequence, selective fetal growth restriction, sympathetic twin, where one twin which is healthy gets compromised because the other twin is compromised without any reason, right? There is something called acardic twin, and in case of monochorionic monoamniotic, like one sac with two twins, cords, so cord entanglement can happen. So cord entanglement can happen only in monochorionic monoamniotic twins. These are all monochorionic monoamniotic twins. So parasitic twin is one twin, instead of the placenta, gets attachment and nutrition from the other twin, and the Siamese twins are attached either by back to back or by heart to heart or by head to head, but they are the same cell mass. How to determine the chorionicity? So if on USG, if it is if they are of different sac and different placenta, then this is thick. So that is T sign. T sign means it is a dichorionic. Whereas if there is a very thin membrane between them, like placenta, this is the lambda. This is the lambda. So lambda is suggestive of monochorionic twin. So when to deliver the twins? For dichorionic twins, 38 weeks. If uncomplicated, monochorionic 37 weeks. But remember, preterm labor is rule rather than exception. So most of the time they will go into preterm labor. So mode of delivery can be vaginal if the first twin is not breech, or transverse if the first twin is cephalic. Then mode of delivery can be vaginal. If first twin is non-cephalic, then it has to go for a cesarean. And triplets always need cesarean. Triplets or onwards. Okay. Just two terms, selective fetal reduction and selective fetal termination, is when IVF is done, sometimes multiple embryos are implanted. Okay. So suppose 4 are implanted and here 2 are implanted. Just imagine, now these two grown bigger, and this one found to be having Down syndrome. So I want to knock out this one, right? So I can do that. That is known as selective fetal termination, okay, which is done late. Late is termination. Whereas if we do it early, then that is selective fetal reduction. So after 13 weeks, I knock off these two. Coming to immunization in pregnancy. So Government of India recommends first dose at TD at the first contact and second dose of TD after 4 to 6 weeks. This is first contact. And other vaccines that are recommended during pregnancy are COVID-19 and influenza. Also this TT, even though Government of India recommends TD, this can be followed with a Boostrix as well. Boostrix is TDAP. Contains acellular pertussis. So what are the vaccines that are contraindicated? HPV vaccine, even though it is indicated postnatally. Postnatally it can be used. MMR vaccine, chickenpox vaccine, zoster vaccine, OPV vaccine, cholera vaccine. Basically live vaccines, unless absolutely needed, are contraindicated in pregnancy. What are the vaccines that can be given? Like yellow fever, JE. All these vaccines can be given if there is an absolute necessary that originates, right? So coming to one important topic, heart disease in pregnancy. So here you should understand one particular concept, that when does a lady with heart disease decompensate? So one particular time is when she is going into the second trimester, because at that time volume expansion is maximum, so the pressure on the heart is maximum. Next is when she goes into labor. Because of pain, there is tachycardia and excessive blood flow to the uterus, so heart has to work more. Highest chance is second stage of labor, not exactly second stage of labor. Then her chance increases at the second stage of labor. Then maximum chance is immediately after delivery, immediate post delivery, because that time a lot of hemodynamic abnormality is going. One side there is bleeding, other side the excess fluid is getting absorbed, there is amniotic fluid gushing. So this is the time where, and there is pain, so this is the time where it's most risky period for heart disease patient to get decompensated and develop pulmonary failure. And one more thing is 5 days after delivery due to infection. So decompensation management, times of decompensation, we know how to management decompensation is a cardiac thing. There's moist O2, propped up position, and the drug of choice is obviously Lasix, that is furosemide, and morphine. Morphine is the drug of choice. Okay, morphine is the drug of choice here because morphine reduces pain, reduces preload, relieves pulmonary edema. Morphine is basically a wonder drug for these women. And prevention, we give epidural morphine. Epidural morphine. This is prevention. All cardiac disease lady should get epidural morphine. So these are the certain things, CARPREG and WHO. These are the scorings basically to understand whether how to understand the risk. So this chart is again available everywhere. You can take a screenshot. This is the WHO category chart. I will just give way for you to take screenshots. So if you see this, these are the conditions where heart disease, where it is absolutely contraindicated to have pregnancy, and if pregnancy is come, it is very 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 high risk. And if you go by it, WHO1, WHO-T, then there is a particular thing called WHO2 or 3. I mean, based on the condition, the lady can be 2 or 3. There is no definite thing. And then there is WHO3 and then there is WHO4. So there are 5 class from 1 to 4. Okay, this is something that you should remember. And all the WHO4 things that you should remember. Now, there is something called bad obstetric history, which is sometimes used similarly as recurrent pregnancy loss, but actually, truly saying, bad obstetric history is basically when there is one event in this pregnancy which can cause a damage to the mother or the baby in the next pregnancy, right? RPL, on the other hand, is recurrent pregnancy loss, which means more than two consecutive losses. And the most important cause rather is APLUS. The other causes are thyroid abnormalities, the sugar abnormalities, rarely due to chromosomal or torch infection. So if there is a case of RPL we are investigating, we generally don't do chromosomal typing and we definitely don't do torch. Okay. So this is again the criteria for APLUS or APLUS syndrome. This is something that you should know. So if laboratory criteria, there is lupus anticoagulant or anticardiolipin antibody or anti-beta-2-GP positive, it has to be positive in 2 occasions, 6 weeks apart, and the same one has to be positive. Like lupus was positive 6 weeks back and now 6 weeks later lupus is negative, but beta-2-GP is positive. That is no. Same one has to be positive twice, plus there should be evidence of thrombosis anywhere in the body, or this is the pregnancy related morbidity. This you should know very very well. It's very important. Unexplained miscarriage more than 10 weeks of gestation, only one, or 3 or more unexplained consecutive miscarriage less than 10 weeks of gestation, or a premature birth before 34 weeks of gestation due to either prematurity or preeclampsia. Okay. So with this we conclude the session on obstetrics, and now we carry on our discussion to gynecology, right? So in gynecology, what is most important is the menstruation and its disorders. So there is a FIGO nomenclature, like previously it was like metrorrhagia, menorrhagia, all those terms. So menorrhagia was like more than 7 days of bleeding or more than 80 ml per bleeding in a cycle. So now FIGO has removed all those terms and put simple terms like HMB. So HMB is heavy menstrual bleeding. Prolonged menstrual bleeding is bleeding more than 7 days. PMB is postmenopausal bleeding, and that's a different. HPMB is heavy and prolonged menstrual bleeding. So basically, AUB is the broad classification. Abnormal uterine bleeding is the broad classification, which means any bleeding in the reproductive age group outside the pregnancy, right? So there is basically two things, AUB or PMB, or yeah, there is basically two things, right? So these new nomenclature terms that you should know, there is irregular menstrual bleeding, which is more than 20 days variation, and intermenstrual bleeding, INB, or intermenstrual bleeding is like, it is not like menstruation, like this is one menstruation, this is one menstruation, this is another menstruation. So these are coming in more or less frequent intervals, but at this point there was some bleeding, and then this point there was some bleeding. So these kind of features are seen in case of cancers or polyps, like something else, that is non-menstrual bleeding is happening, but there is an ulcer, that ulcer when that is getting poked, that is bleeding. So that is one particular thing that needs to be differentiated from the menstrual bleeding. So intermenstrual bleeding, previously this was considered as something called metrorrhagia. All those things were known as metrorrhagia, so those terms are gone. Remember PCB, that is postcoital bleeding, is very important, that is bleeding right after intercourse or during intercourse, and this is very important because this is one of the alarming signs for carcinoma cervix. So what is bleeding outside reproductive age? It is either precocious menstruation when it happens below 9 years of age, and postmenopausal bleeding. So menopause is defined as 1 year. Menopause is defined as 1 year of no bleeding, and there is no other definition, no other test, no other way to understand if the lady is menopausal or not. There is only one thing, that is postmenopausal bleeding is only one thing, that is 1 year of no bleeding. That's only thing that defines menopause. And menopausal transition is given by the straw classification. I think this name is, knowing the name will do. So let us understand amenorrhea now. So what are the physiological causes of amenorrhea? Obviously before menarche, after menopause, during pregnancy and lactation. So primary amenorrhea is defined as when secondary sexual characters are present. After 14 years of age, there is no menarche, or after 16 years of age, there is no secondary sex character and no menarche. That is primary amenorrhea. And secondary amenorrhea is like for 6 months or 3 previous cycle duration, stoppage of menstruation in a lady who has menstruated previously, right? So Tanner stage of development, remember this mnemonic, take a screenshot. I'm not explaining this, but this is a very useful remember. It's made by my USMLE notes for you. She's a blogger. So remember this memo. And also I will not describe the menstrual cycle in details right now for you, because this revision class, this is not a basic foundation class. Just understand one thing, that initial few days of menstrual phase, when the follicles are developing, the estrogen is low, and when estrogen is low, it inhibits luteinizing hormone up in the pituitary. But once the Graafian follicle, the dominant follicle, is selected, it produces high dose of estrogen, and high dose of estrogen has a positive feedback. Instead of a negative feedback, it has a positive feedback on the pituitary, and then there is sudden surge of luteinizing hormone that leads to the ovulation. So that is how it works. And once the ovulation has happened, the Graafian follicle, remnant of it, turns into corpus luteum, and it makes progesterone, and corpus luteum lasts for about 14 days. So that is the second phase of the menstruation period, the luteal phase. So the follicular phase and the luteal phase are the ovarian pattern. So coming to primary amenorrhea. So whenever we are seeing any question of amenorrhea, any complicated question of amenorrhea, see it in it is the problem of which compartment. So either it is a problem of outlet, that is menstruation is actually happening, that will be given by the clues like mid-cycle pain and secondary sexual characteristics and all those things. So it is either a imperforate hymen or a transverse vaginal septum. But if it is not happening, truly not happening, then it is a compartment 1 defect, like uterus is not absent, or a compartment 2 defect, like uterus is absent but the ovaries are not acting, or it's a compartment 3 defect, like something in the pituitary level, or it's a compartment 4, like something in the CNS or hypothalamic level. So think in that line, and always remember this algorithm. So if you find absent or blind vagina, if they talk about it, then if she has normal pubic hair, it is Mullerian agenesis or MRKH syndrome. If she has scanty or absent pubic hair, then it is androgen insensitivity syndrome. Okay. And if she has scant pubic hair and other male-like features, then it can be 5-alpha reductase deficiency. 5-alpha reductase deficiency. 5-alpha reductase deficiency is pubic hair and all will be present, but it is not blind vagina. It is not blind vagina, but you will find testis instead of ovary. You will find testis instead of ovary. So this is 5-alpha reductase deficiency. So this is how you approach the questions when amenorrhea question come in. If they talk about something like blind vagina, but then something bulging in the rectum on parrectal examination, some bluish membrane is seen on speculum examination, so they are talking about either imperforate hymen or transverse vaginal septum. More common is imperforate hymen. So this is cryptomenorrhea, transverse vaginal septum, because the developmental origin, lower urogenital sinus gives rise to the vaginal vestibule, whereas the upper part of vagina comes from the uterine tissue, from the Mullerian system. So if they do not fuse properly at the upper 1/3, lower 2/3 of junction of the vagina, then a septum is formed at that level, and that is known as the transverse vaginal septum. So these are the different types of hymen which can come as your exam as image based question. I think forensic people will also teach you this. So let us talk about the secondary amenorrhea. Let us go into the secondary amenorrhea. So again we will be doing a compartment based analysis, and we will see the Asherman syndrome, which is synechia of the uterine walls. And now coming to one of the most important discussion on polycystic ovarian disease. So polycystic ovarian disease, the names are very important: polycystic ovarian syndrome, or the Steen-Leventhal syndrome, or the Heron syndrome. Heron syndrome because hyperandrogenism, insulin resistance, and acanthosis nigricans. So this is diagnosed by the Rotterdam criteria. Rotterdam criteria, which says two things: oligo or anovulation has to be there, evidence of hyperandrogenism has to be there, either clinical or by increased serum testosterone, right? So clinical is by Ferryman-Galloway score, and there should be polycystic ovaries. So at least 2 out of 3 should be present, and if she is an adolescent, all the 3 has to be present, right? So let us not go into the concept building at this point of time. So this is AMH. AMH is a surrogate marker. AMH is a surrogate marker. AMH is a surrogate marker for ovarian reserve. And direct marker is antral follicular count. Antral follicular count by doing a day 2 TVS. So this is a direct marker and this is surrogate marker. So if AMH is less than 1, then it is low. And if AMH is more than 3, then it is high. Remember this much at least. Coming to the very important topic of contraception, but I will not talk about this topic because if I start talking about this topic, this is endless. There is no end to this discussion basically. So you should know all the images and all the devices, medicines, and this detail, like I mean discussion almost about spanning 1 hour is uploaded in the GamePG app, app, and it is available as a demo class. So I request you, even if you are not in that course, you can go and see it very well. And this is a very important topic. It includes everything of contraception that is known to us till date, and including the immunocontraceptives, the latest thing. So coming to infertility, what is infertility? Infertility is 1 year of married life, unprotected, unlimited sexual intercourse, and still the couple is not able to become pregnant. Right? That is what is infertility. So, basic cause of infertility has to be approached, like whether they are aware of the proper techniques of coitus, and if there is any diabetes, or if somebody is having severe alcoholism, or severe tobacco dependence and erectile dysfunction, anything. So detailed conjugal history and basic medical testing, like testing for thyroid problems and sugar problems, all those things has to be done. And once all these are done, then we are left with then we are left with then we are left with two things: the male factor and the female factor. Sorry, the female factor, the male factor, and both partners, and unexplained. Right? So this is about 33%, this is about 33%, these two combined are about 33%. So the first core infertility investigation is husband semen analysis. Don't see this chart. You go to my Instagram handle. You have remembered, I think by now, that Dr. Sunabha. You will find the latest WHO semen analysis parameter that is released in 2023, uploaded there, and you read that. Don't read this. Remember, morphology is diagnosed by strict Kugerberg-Treiber criteria. Necrospermia is dead sperm. Globospermia is sperm with deformed heads. And if number of sperms are less, it is oligospermia. If the sperms are non-motile, it is asthenospermia. If they are of abnormal morphology, this teratospermia, and together they are OATS, oligoasthenoteratospermia. Okay. So again, coming to male infertility, and this is like the same way we have in case of anovulation or amenorrhea, we have discussed compartment wise. So here also we will discuss compartment wise. So male infertility, retrograde ejaculation, that is ejaculation into the uterine urinary bladder, that can happen. So retrograde ejaculation is very much common after prostate surgeries. Then a problem beyond testis, like something is blocking the testis, like stenosis, or surgical clip, like your male sterilization, or a congenital problem like congenital absence of bilateral vas difference, or Carter-Jenner syndrome, where the vas difference is there but the cilia are non-motile and cannot take the sperm ahead. And then it can be a testicular problem, either congenital or acquired, or a pretesticular problem like a pituitary or a hypothalamic problem. Right? So impotence or ED is something very important, something that you should definitely know of. So these are the risk factors for erectile dysfunction. And the drug of choices are sildenafil, which is also very well known as by its brand name Viagra. Then tadalafil, vardenafil, avanafil. Avanafil is the latest kid on the block, and actually it is very less interaction with food, so it can be taken with food as well. Okay, and yeah, this is something. So coming to the female factor, if there is an uterine factor, we can diagnose it by transvaginal sonography. If it is a tubal issue, then we can diagnose it by a hysterosalpingogram or a sonosalpingogram or hycosi. Hycosi is ultrasonic contrast, basically contrast sonography, or the final gold standard method is doing a diagnostic hysterolaparoscopy or a laparoscopic chromoperturbation. So these are the techniques to understand whether she is ovulating. The LH kits are the latest kit in the block, and the best one is TVS folliculometry. Cervical factor is like if cervix has anti-sperm antibodies, and that is better understood by something known as the Sims-Hanner test, which is also known as postcoital test. Postcoital test, but this is not done nowadays. So HSG, these are the things. This is known as the Leash-Wilkinson cannula. Wilkinson cannula. This is known as the hysteroject. This is known as the Mobius cannula. So we use iodine dye, we use iodine based dye, and any infection, current pregnancy, and allergy to iodine based dye is a contraindication, right? So these are the images. I think you know that. Just to compare, this is the same image, only the positive and the negative, and you cannot comment on the uterine body based on. So this is not a bicornuate or arcuate uterus. To comment that, we need to see the uterus from outside through a laparoscope, right? So this is proximal or cornual block, again can be due to spasm, or a true block needs hysteroscopy and laparoscopy. These are distal femoral block showing massive hydrosalpinx. This is a very smooth rounded filling defect with dye passing around it, so this is most likely to be a polyp or a fibroid, whereas this is scattered and irregular filling defect, so this might be Asherman syndrome. So these are the images of like laparoscopic chromoperturbation. We can see the intact fundus, and when dye is injected from below, we can see bilateral spillage of the dye. On the other hand, this is the hysteroscopic view. This is the hysteroscopic scissor you can see, and you can see there is adhesion between the anterior wall and the posterior wall, and no cornu is visible. So the scissors will go and cut this adhesion, and that is the treatment of Asherman syndrome or uterine synochia. So coming to ovulation induction is basically to give drugs that will force form the ovulation induction agents. So letrozole is an agent which is generally targets a single ovulation, whereas clomiphene causes multiple ovulation. Also, the other things are used are human menopausal gonadotropin or follicle stimulating hormone. Human menopausal gonadotropin is basically FSH only. Okay, it is just a different form of gather, but it's the same thing. So if somebody gives you this image, you know this is OHSS, but you should understand the proper history should be there, otherwise it can be a mucinous cystadenocarcinoma of the ovary as well. So coming to two things, minimal assisted reproduction and artificial reproductive techniques. So artificial reproductive technique is basically in vitro fertilization, where the fertilization happens outside the body, whatever we do, and MARs are when the fertilization happens inside the body. So IUI, ovulation induction, all these things come under MAR, whereas IVF, ICSI, all those things happen are ART. So this is the intrauterine insemination cannulas. So this is how the sperm and not semen. Okay, intrauterine insemination is not semen but sperm. Sperms are directly injected into the uterus. Okay, this is the oocyte retrieval device. This is how TVS is done, and through the TVS guide, this probe is inserted and the ovum is picked up from the developing follicle. You can see this is ICSI being performed, intracytoplasmic semen instillation. So here this is a ovum. This is the first polar body at the 12 o'clock position, and this is a micropipette injecting the male pronucleus inside the ovarian cytoplasm. So this is ICSI being performed, right? So different testicular aspiration techniques, doing testicular biopsy, that is doing testicular biopsy, testicular semen aspiration, this is testicular semen extraction, this is percutaneous semen aspiration, this is microsurgical semen aspiration, this is retitesticular. So these four full form at least should be known. Okay, coming to genital infections, vaginitis are three mainly you should know: bacterial vaginosis, candidiasis, and trichomoniasis. I have detailed videos on genital infection on YouTube channel, GAMEPGAPP YouTube channel on this. So if you go through it, it's a 5 minutes of video and there should not be any confusion if you see that video. Okay, so vaginal defense mechanism basically comes from estrogen, remember that. So bacterial vaginosis, all these things we have discussed there. So coming to the cervicitis, if cervicitis is definitely a sexually transmitted infection and partner treatment is needed, chlamydia and gonorrhea are the two differentials. And when we see gonorrhea, we should also treat for chlamydia because chlamydia is the most common STI overall. Okay, so if the infection has gone beyond the cervix and gone to the uterus or to the tubes, it is known as PID. Remember, all the PIDs are ascending. That is, first there is a cervical infection and then it goes to the uterus and then to the tubes. Only tuberculosis, which is a hematogenous spread, comes from the tube and then spreads below, and rarely vaginal or cervical tuberculosis we get to see. So again, if you want a discussion on tuberculosis, that is also there in my Instagram account. You can go and see step by step how tuberculosis affects the tube and the stages and different named appearance, which you should definitely know. So this is another chart which you should definitely know at the NACO, the National AIDS Control Organization, NACO colored kits. This is something that you should know absolutely. Like, you should not be going to the exam not knowing this. Okay, and this is not today's class that we teach this. Okay, I will just briefly say it. Kit 1 is a grey kit, that is for cervical discharge. So we know the organisms are chlamydia and gonorrhea. So for gonorrhea, cefixime 400 mg 1 dose. For chlamydia, azithromycin 1 gram 1 dose. Kit 2 is green. So the contenders are candida, so fluconazole 150 mg 1 tab. Then bacterial vaginosis and trichomonas, both gets knocked off with the same drug, secnidazole 2 gram 1 tab, right? So likewise, so genital tuberculosis, this is something that should see. Now coming to the discussion on dysmenorrhea. So dysmenorrhea, mostly of three types: spasmodic dysmenorrhea, which is periods pain during the periods; congestive dysmenorrhea, which is because of pelvic congestion and it gets relieved with menstruation; And then there is the worst triple dysmenorrhea, where there is spasmodic, there is congestive, and there is dysmenorrhea even after the period is over. So this is typical of endometriosis. This is typical of endometriosis. Okay. So chronic pelvic pain is something that is beyond discussion of this thing. Adhesion is one of the most important, and remember this image. This is published with permission of patient. This is my own case when I was doing a diagnostic laparoscopy for infertility. I found this. So this is the violin string perihepatic adhesions in a case of PID, which is known as the Fitzhugh-Curtis syndrome. Fitzhugh-Curtis syndrome, right? So, endometriosis, this is a very important table. So, endometriosis is basically ectopic endometrium. Like endometrium is present but outside the uterus. So, obviously, that is swelling up during the luteal phase, and there is pain, and then, sorry, the follicular phase, then they become turgid and thick, causing pain, and then when they bleed inside the pelvic cavity, which causes severe irritation. So how does this endometriotic tissue get outside the uterus? So there are certain theories, like when she is menstruating, the blood comes through the vagina, and some blood comes through the tube and implants on the pelvic floor. So that is Sampson's retrograde menstruation therapy theory. And then there is lymphatic spread therapy theory by Halban, and vascular metaplasia theory. Then coelomic metaplasia, like some normal tissue of the pelvic peritoneum becomes metaplastic and becoming endometriosis. So that is Mayer and Ivanov's theory. So all these things are there. Remember, endometriosis, the mainstay of management is pain management, and dynogest and anti-androgenic anti-inflammatory immunomodulator fourth generation progesterone is currently the drug of choice. Okay, is currently the drug of choice. So what else can be used? All those GnRH agonist or antagonist, like leuprolide, like our leuprolide, or goserelin, GnRH antagonist like leuprolide, agonist like goserelin, it is a subcut injection. Then elagolix, it is a oral congener, again new thing. And nafarelin is nasal. So all these drugs. Okay. And then surgical complete excision of the tumor, but remember, surgical has no role in diagnosis. Diagnosis is not surgical. Diagnosis is absolutely not by diagnostic hysteroscopy or laparoscopy. That has changed now. Diagnosis is TVS, and clinical diagnostic hysteroscopy is out by recent ESHRE guideline. Okay. Mirena can also be used. Mirena is LNGIUS, levonorgestrel intrauterine system, is also used. Right. So if you see a question on chronic pelvic pain, if they are talking about a hot burning electric shock like pain, it is nerve entrapment. If they talk about pain fluctuates with menstrual cycle, it is adenomyosis or endometriosis. If they talk with pain with urge to void, then it is intestinal cystitis or a urethral problem. If they talk about postmenopausal pain or any other things like breathlessness, weight loss, all these things, then malignancy. If in the question they talk about prior abdominal surgery, then they want to point you towards adhesions. Or if they give history of bowel symptoms, then they are talking about inflammatory bowel disease. So in your question you should be very careful to pick up the subtle hints if it is a clinical situation. Okay, so coming to the red flag syndromes. Now, red flag syndromes are things which needs immediate attention, like bleeding per rectum, new bowel symptoms over 50 years of age, new pain after menopause, pelvic mass, suicidal ideation, excessive weight loss, irregular vaginal bleeding over 40 years of age. Any irregular vaginal bleeding over 40 years of age needs a colposcopy plus hysteroscopy with, if cervical biopsy and endometrial biopsy if needed. Most of the cases, at least endometrial biopsy. And postcoital bleeding. So, pain relief is the cornerstone of treatment of chronic pelvic pain. Otherwise, the pain becomes the symptom and everything else becomes secondary. Okay. So, starting with gynecological oncology, so endometrial cancer. Endometrial cancer usually presents with postmenopausal bleeding. There are certain things we will see that. First, let us discuss about the postmenopausal bleeding. So, most common cause of India, it is CA cervix, not CA endometrium. Okay. Most common global cause is atrophic endometritis. Most common uterine cause in India is atrophic endometritis. Okay, and CA endometrium is seen in 10%. So this number is very, very important, 10%, that you should always know. Okay. So what are the CA endometrium risk factors? CA endometrium risk factor is the triad of unopposed estrogen like early menarche, late menopause, and nulliparity. Then anovulatory infertility, PCOS. Tamoxifen is a particular drug which is given for breast cancer management. So that drug can cause CA endometrium. Estrogen alone, HRT, hormone replacement therapy. And the metabolic problems like obesity, hypertension, diabetes, which is combined with uterine cancer, is known as the corpus cancer syndrome. And it is like the metabolic disease X, right? And protective factors are multiparity, OCP. OCP, remember, protects against three cancers: CEO. Okay, so colon, endometrium, and ovary. Smoking is anti-estrogen, and hence smoking is protective for C endometrium, but it can cause many other cancers. So don't jump ahead and start smoking. And of course, exercise. So see, there is a metabolic risk factor and there is a metabolic risk reducer. There are genetically associated cancers like HNPCC, Lynch 2 syndrome, DNA MMR, and mismatch repair gene defects, and P53 mutation. P53 mutation, that is only. So, these cancers present a decade earlier and have family history of endometrium or family history of other associated cancers like colon and all. So for them, the treatment is screening is starting from 35 years with TVS ET, and surgery is risk reducing TLH-BSO once family is complete or at 35 years of age. Right. So this chart is very, very important. This is chart is very, very important. This is talking about the type 1 and type 2 cancers. So type 1 is 80% endometrioid, mostly endometrioid. These are obese women, pre-perimenopausal, pre-invasive lesions. I mean, there is a gradual progression. First, the in situ type of lesion, then the invasive lesions, and follow endometrial hyperplasia. Starts with endometrial hyperplasia, is estrogen responsive. And type 2 is exactly opposite. It is the bad or aggressive histologies, lean patients, postmenopausal, no pre-invasive stage. Atrophic endometrium is the base, no underlying hyperplasia, and these are estrogen independent, right? So Simpson pain is referred pain in hypogastrium. This is seen in Endometrium, and workup is first of all biopsy, then MRI to understand cervical involvement or depth or lymph node, CT scan for lymph node analysis, and genetic testing, NGS and poly. Actually, 2023 Figo has totally revolutionized the staging of endometrial cancer, and I will put a detailed video in coming 2-3 days, so don't worry about it. So CA endometrium staging is something I'm not discussing at this occasion. Okay. So treatment or surgical staging, all these things will come on my upcoming video, because Figo has changed everything. So coming to the discussion of CA cervix with the HPV and HPV related things. So CA cervix, first of all, understand that CA cervix is an STI. Okay. CA cervix is a sexually transmitted infection. Most common cause of postmenopausal bleeding in Indian women, and most common cause of pyometra in Indian women. Okay. So what are the CA cervix risk factors? Exactly opposite to the endometrium. Early intercourse, too many children, too quick, frequent intervals, and too early, like low age at first childbearing. Multiple partners, concomitant other STI like HIV, and low socioeconomic status. Smoking is associated with squamous cell carcinoma, whereas OCP is associated with young CA cervix adenocarcinoma. CA cervix is not much family associated. So squamous cell carcinoma is most commonly arises from ectocervix or the transitional zone, and adenocarcinoma is most commonly from HPV-18 related and most commonly from the endocervix. Remember, skip lesion is seen in adenocarcinoma. So clinical examination and all I don't want to discuss at this point of time. CA cervix staging is something you should know, that I am also not discussing at this point, but understand the certain changes has been done for the stage, that is it is turned into a clinico-radiological classification rather than purely clinical classification. Use of adjuvants like cystoscopy, sigmoidoscopy, all these things have been attached. 1A is modified. Previously 1A was classified based on lateral spared and depth of invasion. Now it is only by depth of invasion. There is added something like 1B3, which is stage 1 but more than 4 centimeters, so limited to the cervix but more than 4 centimeter lesion, which is known as early Wilkie disease. It's a non-operable lesion. And stage 3C, because we have introduced imaging, now we get to know whether lymph nodes are involved or not. So if lymph node is involvement, it is stage 3, there is a new stage. So this is the stage wise management of CA cervix, and this is what you should be taking screenshot and save and read. There is fertility preserving surgeries on the left side, and the fertility the complete surgery on the right side. Remember, Dargent operation, the other name is radical trachelectomy, right? So let us discuss HPV. Particularly 16 and 18 causes 70% of the lesions. 18 is adenospecific. 6 and 11 causes warts. So when we had first vaccine, we had 16-18, which is Cervarix. Then we had 4 valent. So we included 6, 11, 16 and 18, that is Gardasil. Now we have Gardasil 9, which has 6, 11, 16, 18 definitely, then 31, 33, 45, 52, 58. This is a question you should remember. Another thing you should remember is the protein structure of HPV. I think microbiology you will be taught about it, but E1 and E2 are the replication proteins, E6 is P50 inhibitor, and E7 is RB inhibitor in case of HPV viral genome structure. So cervical cancer screening is primarily by HPV DNA PCR, now WHO says. Also can be done by exfoliative cytology, by liquid based cytology, or pap smear. So you should know these things. This is Ayer spatula, this is Ayer spatula, this is the cyto brush, where this is the cyto broom. Cytobroom is used for liquid based cytology. These outer brushes are for ectocervix, inner brushes are for endocervix, whereas Ayer spatula, the spatula is for ectocervix and this brush is for endocervix. Also, visual inspection with acetic acid or Lugol's iodine via and Vili are still done. Like you can see here, this area has become whitened. This is called the aceto white test, aceto white. And if you see this one, the same area on giving Lugol's iodine, this area has not taken the color of the iodine, because there is a character of cancer is sugar hunger. So in this area where cancer is developing, the glycogen is used up. That's why it is not stained with Lugol's iodine, right? That's why it is not stained with Lugol's iodine. Understood? So, how to report PAP? PAP can be either normal, that is negative for intraepithelial lesions or malignancy. Then it can be abnormal squamous cells of unknown significance, abnormal squamous cell high grade, then LCIL, which is like CIN1, HCIL, which is like high grade squamous intraepithelial lesion, and this is low grade squamous intraepithelial lesion. Or glandular abnormality, like glandular abnormality of unknown significance or suggestive of glandular malignancy. So post hysterectomy, we need not to screen for PAPs. Vaccinated girls needs to be scanned. For people living with HIV, it is yearly or annual scanning, whereas for other women, HPV DNA PCR is 5 yearly and simple PAP or liquid based cytology is 3 yearly. Okay. So what to do if PAP's report is abnormal? If it is something like CIN1 or CIN2, CIN1 we will do annual PAP and we will do treatment if it is static for 2 years. That is, does not resolve by 2 years. CIN2, we need to do a cryoablation or loop electrosurgical excision. CIN3, the treatment is conization or simple hysterectomy. So this is the cryotherapy. This is the cryotherapy probe. We use minus 20 degree nitrous oxide. And depth reached is about 5 millimeter. This is loop electrosurgical procedure, loop electrosurgical excision procedure, or electrosurgical excision of the transformation zone. So these are the various electrosurgical equipments that can be used for this procedure. And conization is cold scissor conization and can be done. So remember, this is the only thing that can address a endocervical issue. This is the only thing that can address a endocervical tissue. So coming to another rather atypical thing, the molar pregnancies. So molar pregnancy, this difference between complete mole and partial mole, I don't think you need not to explain. Understand that partial mole is triploid, whereas complete mole is mostly diploid. P57 KEEP2 is something that is important. It is paternally silenced in complete mole but stains positive in partial mole. Okay, and malignant conversion is higher with complete mole, right? So coming to clinical presentation, it is most always incidental by USG, and what is the appearance known as snowstorm appearance, whereas partial mole will be partial vesicular degeneration with cystic placenta with features like incomplete abortion. Fetal parts can be seen, right? So pre-evacuation beta HCG is important, and there should be follow-up. There should be follow-up. And how long this follow-up should be? Follow-up should be weekly till 3 normal values and then monthly for 6 months. Okay. Follow-up is weekly till 3 normal values and monthly for 6 months. And this follow-up period, contraception is must, barrier is best, but OCP can be used. IUD is contraindicated. So when to do chemotherapy? When there is a beta HCG rise over 2 values. When there is beta HCG rise over 3 values, that is 2 weeks, or beta HCG plateaus over 4 values, that is 3 weeks, or persistent beta HCG after 6 months, or beta HCG is above 20,000 at any point of time, or there is clinical indications like bleeding or a lung lesion or a vaginal lesion. Remember, if there is a vaginal lesion in a mole follow-up, you need not to do a biopsy of that thing, but start chemotherapy, because it's a highly vascular and highly chemosensitive lesions, so biopsy is not indicated. So malignant histopathology are either invasive mole or choriocarcinoma. If it is choriocarcinoma, it is both cyto and syncytio, so dimorphic cells. And if it is placental site trophoblastic tumor or endothelial trophoblastic tumor, then it is monomorphic cell consisting of only intermediate trophoblast, right? So most common neoplasia is invasive mole followed by choriocarcinoma followed by these 2 rare types. Most common gestational trophoblastic neoplasia after mole is invasive mole followed by CC. Choriocarcinoma develop most commonly after complete mole, and most common neoplasia after a term pregnancy is choriocarcinoma. So remember this one, rest is logical, right? So clinical presentation can be like a missed abortion as well, or through a direct metastasis to the lung. Remember, staging does not change the prognosis, and what is important for prognosis is this WHO risk classification. So this is something that you should be knowing. This is again something that you should be knowing. Take a screenshot and mug up. There is no other way. So treatment, if it is a low risk disease like 0 to 6 is the risk score, then methotrexate is the drug of choice. If methotrexate is contraindicated, you can use actinomycin D. 7 to 12 high score gets EMACO regime. And remember, the C in EMACO stands for vincristine. Okay. C doesn't stand for vincristine. O is oncovin, which is vincristine. But you should remember that it is not vinblastine, because it has C. You can relate with the C of vincristine. Okay. C is cyclophosphamide. E is etoposide. A is adriamycin. If it is more than 12, then it is considered as ultra high, and the treatment is EP induction, that is etoposide and induction, and then IMA-EP for the follow-up. So for malignancy, beta HCG, every 2 weeks beta HCG and chemo. Once beta HCG is normal, normal, 3 cycles of further chemotherapy, and then monthly beta HCG. For low risk disease, follow-up is for 1 year, whereas high risk disease, follow-up is for 2 years. So ovarian cancer, these are the one-liners. Again, take a screenshot and try to understand all those things. These are not very, rocket science. So WHO classification of ovarian neoplasm: epithelial ovarian, germ cell tumor, sex cord stromal tumor, and the metastatic tumors. So again, ovarian tumors is something that is protective factors are multiparity, breastfeeding, self-injectomy, hysterectomy, tubal ligation, and OCPs. On the other hand, risk factors are age, hyperestrogen triad that we have seen in then delayed childbearing, Caucasian race. 10% of them are hereditary, and smoking is a risk factor, particularly for the mucinous type. Okay, so these are the genetically associated cancers: 17q, BRCA1, 13q is the location of BRCA2, and HNPCC. So, coming to the types of epithelial ovarian cancers, the general marker of epithelial ovarian cancer is CA125, which was also known as MUC16, and this tells you that these are basically mucopolysaccharide group of molecules. So there is type 1 or low grade and type 2 or high grade, which is KRAS or BRAF. P53 is usually considered as high grade serous and of tubal origin. So mucinous special marker is CA99 and CE, and appendectomy may be required in certain cases. Clear cell is rare and the histopathological type is Hobnail pattern. Brenner is very rare and it can also present something like Meeg syndrome, so it is associated with pseudo-Meeg. These Brenners develop from Walther cell nest. Okay. So coming to the germ cell tumors, the dermoid cyst or benign cystic teratoma or mature cystic teratoma, these are filled up with layers from all three germ cell layers, specially filled up with hairs and teeth. So wherever there is a teeth or a bony protuberance inside it is a Rokitansky protuberance, and this is the site where malignancy is most likely to begin with. And dash and dot pattern is like hairs and nails, and like this irregular pattern that is seen is known as dash and dot pattern. So less than 2% malignant conversion, and there is no particular malignant tumor that is associated with it, because each component, there is components from all the three layers, so each component can lead to malignant transformation. Coming to the other germ cell tumors, dysgerminoma, it happens from dysgenetic gonads. The marker is mainly LDH, also PLAP and HCG. Remember, 15% of these lesions are bilateral. Then immature teratoma is a lichen benign cystic teratoma with neural content in it. So benign cystic teratoma, malignant conversion is not malignant cystic teratoma. Okay, malignant cystic teratoma or immature teratoma is when there is neural component in it. Then there is endodermal sinus tumor or yolk sac tumor. The marker is alpha fetoprotein. Embryonal cell cancer, marker is both alpha fetoprotein and HCG. And ovarian choriocarcinoma, where the marker is beta HCG. Now remember Schiller-Duval body, which is associated with yolk sac tumor. Now the sex cord stromal tumors, granulosa cell tumor, which marker is inhibin and estrogen, but estrogen is not a very useful marker because estrogen can be high for so many other reasons in a female. So col external body and with coffee bean nuclei is the marker. Theca cell tumor, it secretes androgens, so there is evidence of virilization. So Ringkiss crystals can be seen on histopathology. See, this theca cell and granulosa cell, these are the two sex cord stromal tumor, right? So theca cell produces androgens under influence of luteinizing hormone, and under the influence of follicular stimulating hormone, granulosa cell converts this androgen into estrogen, right? This is the two cell two gonadotrophin theory. So theca cell produces androgenic tumors, so causes virilization, and Ringkiss crystals are seen on histopathology. Sartoli Leydig cell tumor again is very rare. Fibroma is benign, unilateral and solid. It is like a solid tumor, and when it is present, it can lead to ascites and right pleural effusion, which is known as the Meek syndrome. This is a right pleural effusion, remember. Okay, and if some other solid tumor is causing the same picture, that is known as pseudo-Meek syndrome, and most common is Brenner, that we have already seen. So Krukenberg are smooth bilateral symmetrical tumors. Histopathology is signet ring cells, and most common source is stomach, then bowel, then breast. Most common cancer metastatic to ovary is CA endometrium, but this is not Krukenberg. Most common extragenital cancer that mets to ovary, this is adenocarcinoma, but this is surface deposit. Okay. So ovarian cancer treatment is basically chemo followed by surgery. That is known as ovarian cancer staging. Staging I will not tell. Treatment is either chemo followed by surgery or surgery followed by chemo. So this is known as, this particular surgery, this is neoadjuvant chemo followed by surgery. So this is interval cytoreduction, interval cytoreductive surgery. Whereas when we do surgery followed by adjuvant chemo, it is known as primary cytoreduction, primary cytoreductive surgery. So if there is a recurrence and we are doing cytoreduction, that is secondary cytoreductive surgery. And secondary cytoreductive surgery is not just the opposite of primary cytoreductive surgery. That is primary versus interval. Okay. And there is one more surgery which is called a staging laparotomy, or staging laparoscopy, which is when I am not sure of the histopathology of a suspicious mass, I am doing the surgery with a staging intent, removing omentum. Of course, I am doing hysterectomy with bilateral tubes and ovaries with omentum, with nodes, and sent for histopathology to understand the stage as well as histopathology. That is known as staging laparotomy. So staging laparotomy is done when the diagnosis of malignancy is not in hand. Okay. Coming to one of the very important topic, pelvic organ prolapse. So what prevents prolapse? The supports of the uterus, right? Supports of the uterus. So two things. One is this odd angle of the uterus to the bladder. So there are two angulations. One is uterine corpus to cervix and one is cervix to vagina. So the one related to vagina is known as version and one related to the corpus is known as the flexion. So cervix to corpus is flexion, cervix to vagina is version. Uterus is normally anti-verted, anti-flexed. Okay. So there are the two round ligaments which are the false supports, and then the main support of uterus on two sides, the two Mackenrod's ligaments, and anteriorly through the pubis, the pubocervicalis, and posteriorly to the sacrum, the uterosacrals, pair of uterosacrals and pubocervicalis. So these are the main first line, the first level of support for the uterus. Second level of support is the fascia of the levator ani, and third level of support is levator ani muscle itself, and these are known as the De Lancey's levels of support. Right, these are known as the De Lancey's levels of support, and one particular area of the support is gone, that particular pelvic organ gets prolapsed. Not only the uterus, can be the rectum, can be the urethra, can be the rectum, depending on the weight. If there is a prolapse of the POD, it is known as enterocele. Don't think enterocele is the prolapse of enteric area or the intestines. It is the prolapse of POD. Okay. So prolapse can be childbirth related, or it can be related to chronic ligament weakness, especially nulliparous prolapse. Okay. So Marfan syndrome, Ehlers-Danlos syndrome, spina bifida, all these are to be investigated or looked for in case of nulliparous prolapse. So, what causes prolapse? Chronic cough or COPD, constipation, pelvic SOL, weightlifting, obesity. So, whatever we think is causing increased intra-abdominal pressure, also whatever causes weakness like age or menopausal status, race, pelvic floor, non-obstetric trauma, all these things. Okay. So there are certain classifications of POP. So one is POP quantification score or the POPQ classification, and one is Shaw's classification that we typically know, like grade 1 prolapse, grade 2 prolapse, grade 3 prolapse. So remember Shaw's classification, hymen is a sorry, introitus is taken as the reference point, and it is described in the degrees of prolapse. So first degree prolapse is slight prolapse, second degree prolapse is prolapse up to introitus, third degree prolapse is prolapse beyond introitus, and fourth degree or precedentia is when even the fundus has come out. POPQ classification talks about stage, not degree, and the reference point is hymen. There is another system called Beden-Walker halfway system where hymen is the reference point and it is described in grade. So degree, stage, grade. At least remember these two. So what are the non-surgical management? Kegel's exercise, that is pelvic floor exercise. Then there are pessaries, estrogen supplementation, lifestyle modification, and finally surgical modifications, finally surgical corrections. So pessary, again there is a detailed video on pessary on my GAMEPGAPP YouTube channel, GAMEPG app YouTube channel, then you're encouraged to go and see that video. So what are the surgeries? Surgery is Ward Mayo versus Manchester. Ward Mayo is basically vaginal hysterectomy with pelvic floor repair, whereas Manchester is cervical amputation DNE with pelvic floor repair with anterior plication of the Macken rod. Okay. So there are certain surgeries for nulliparous prolapse. You should know the names at least: Khanna's, Purandares, Shirodkar, Virkund, and cervicopexy, hysteropexy, which a surgery is done using mesh implant. Surgeries for young multiparous prolapse are basically all those sling surgeries and mesh surgeries. So what are the surgeries for vault prolapse? Vault prolapse is basically when the vault of the vagina comes out, prolapse out after a hysterectomy, right? After a hysterectomy. So these are the surgeries that can be done for cord prolapse. Coming to incontinence, the one that I would, 2 points I would like to talk about is the primary investigation. The first investigation starts with rule out UTI. Okay, UTI is the most common cause of stress urinary incontinence is due to mostly hypermobility of the uterus, and a Q-tip test can diagnose the hypermobility. And basically what happens is, normal condition, the urethra should be like this. So if urethra is like this, then it starts dripping. So our job is to surgically sling this urethra back in its normal position, preventing the hypermobility, right? So that surgical correction is done by two particular surgeries: the transvaginal taping and transobturator taping. The transvaginal taping and the transobturator taping are the surgical correction of SUI or stress urinary incontinence. Now this is very important: palm coin classification of the AUB, abnormal uterine bleeding, polyp, adenomyosis, leiomyoma, malignancy. These four are the uterine causes. Then coagulopathy, ovulatory dysfunction, then iatrogenic. There is nothing for E, and N is not specified. So these are non-uterine. So this is the palm coin classification that you should know. Then adenomyosis, I will just give you a brief description on fibroid versus adenomyosis. So here you can see a smooth enlargement, whereas this is an eccentric enlargement. This can be multiple, this is single. This is infiltration of glandular tissue inside the myometrium. This is abnormal growth of myometrium. So this is tender, this is non-tender on examination. This is irregular, this is a regular globular thing. So fibroid and adenomyosis distinction is pretty easy and straightforward. I think all of you will be able to do that. So know this fibroid Figo classification, know which one is what. This is very much self-explanatory and I'm not explaining it. So what are the minimal and non-invasive options of fibroid? So that you should know, there are certain things. Starts with embolization of the uterine artery. Okay, embolization of the uterine artery. Next thing that is there is HIFU, high intensity focused ultrasound. High intensity focused ultrasound. Embolization of the uterine artery, high intensity focused ultrasound. These are coming as non-invasive or minimally invasive fibroid management strategies, and just the full form may be casually asked in your exam. Okay. So type of hysterectomy, if we cut here, here and here, that is simple hysterectomy. If we leave the cervix, as we have discussed in obstetrics, it is subtotal hysterectomy. If we also remove the paracolpos along with it, it's a radical hysterectomy. And if we apply that clamp, at the pelvic brim, at the pelvic side wall, it is known as extended hysterectomy. This is not very difficult, don't break your head on it. And remember, whether we are removing ovaries or tubes or lymph nodes is not related to the definition of hysterectomy. Finally, we will conclude our session on the HRT, describing the HRT drug. I think pharmacology it will be discussed. So remember two things, that is estrogen plus progesterone if uterus is there. Only estrogen is enough if uterus is not there. You can use tamoxifen, but it increases the chance of uterine CA. Raloxifene can be used, but it is not bone protective. And new drug is tibolone. New drug is the tibolone. One more drug was there, danazol. It is no longer recommended. So new drug is tibolone. Tibolone is one of the most important drugs right now in the management of postmenstrual syndromes. I think we had a very high intense discussion, and a lot of things I left understanding that you already know, or a lot of things I have already discussed in YouTube channel and Instagram handle. So all those topics I have not covered. If you have any particular doubt or want clarification or want any high yield topics discussion, do let me know. My Instagram handle is DRSUNABHA, or send it to the GAMEPG app. Okay, best of luck. We'll see you on our NEET PG preparation session once you have cleared your FMG in fine colors. Thank you.